We want to thank everybody that has joined us virtually for this part two in clinical research roadshow. We are so lucky to have Dr. Maureen Tierney with us, the Associate Dean and Chair for Clinical Research in the School of Medicine, and also Dr. Ryan Walters, the Vice Chair for Clinical Research, and he's really our statistics guru as well. Has so much knowledge about that. We are going to be talking about understanding research principles. They have a lot of great information for us today. I will be about halfway through and towards the end sending you on the chat the CE credit activity code. So you will be getting that for CE credit if you would like that. Thank you so much again for being here. And if you have any questions, feel free to unmute, or you can put them in the chat and I can get those to Maureen and Ryan. All right, Dr. Tierney, take it away.
Hi, everybody. We are doing this from balmy Omaha. It is now actually over freezing for the first time. So we're thawing out and therefore we can actually talk without our teeth chattering. So we wanted to share with you, actually Ryan's going to do most of the sharing because he's an extraordinary teacher of statistical principles and trial design. But if we could have the next slide. So, in November of 23, there were two Research Roadshow number ones, one on the Omaha campus, one on the Phoenix campus, that focused in a large degree on the research infrastructure. Who do you go to for what? How do you get a research proposal through the CRO to the IRB? Some suggestions about funding and going through that process at Creighton. So those slides and those talks are available from Brianna Conyers in the Office of Research, and also on the particular campuses from Miguel Labrego or Sandy Byers. I would highly suggest everybody who wants to do research at all, keep a copy of those slides because they are a great resource. So today, what we wanted to do is talk a little bit more generally about question and hypothesis generation. And this is a topic that can be for individuals, faculty who want to mentor, fellows or residents who are designing, and students who are designing their new protocols and new questions. And then lastly, we're going to talk a little bit about what are some of the basics of mentoring. Some of it is very, guideline specific as to what a mentor is required to do. And then some suggestions about how best to do that. And then lastly, refer you to some more in-depth resources that Dr. Hansen, Brianna, and a number of other people have been supporting and providing on more in-depth mentoring opportunities. So with that, I'll turn it over to Ryan.
Okay. The next two sections are research and hypothesis development. So let's talk about research question development first. One of the questions I've gotten many times over the past 17 years is, how do I develop a research question, or where can I find one? And to be honest with you, the answer is they're kind of everywhere. And one thing that you want to keep in mind is that your clinical mentor and the idea person might not be the same person. This is something that I've come to realize probably more recently in the last 5 years. There are a lot of individuals working clinically who have a lot of ideas, who have no interest in actually pursuing the research to answer that question. And so when you identify an idea person, just stand by them and listen to what comes out of their mouths, to be honest with you. If you don't have a specific idea person in mind, you can also just kind of keep your antenna up during your clinical practice, conversations with your colleagues, maybe in the shower when you're not even thinking about research at all, or in the literature. And that's really the best place to find your ideas. You got to read. So most research publications are written in a very structured format. If you go to the second to last or third to last paragraph of almost any discussion section for any publication for clinical research, you're going to find limitations. Now, most authors aren't going to speak so poorly of their article that everyone questions why the study was even done. So the way they kind of offset those limitations is to couple them very closely with ideas for future research direction. So the more you read, the more questions are going to come up. Further, the more you get involved in research, and again, you have to start somewhere, but the more you get involved in research, the more questions are going to come up. To be honest with you, every project that my team completes with folks generates between 2 and 10 additional questions. So it kind of snowballs on itself. So research questions in general, primary requirement is a good idea. It should be quantifiable, verifiable, replicable, and defensible. Now I have replicable in red font. Replication crisis is very real. Publishing for the sake of publishing is not super great to the advancement of science overall. So you really want to make sure that your question has clinical utility and it's likely to replicate in different settings. One of the key items is basically that everything must have an operational definition. And the way that I kind of teach how to generate these operational definitions is by using either PICO or PCOT format. It's an acronym, stands for Population, Intervention, Comparison, Outcome, and Time. Now, I'm a statistician by training, but I talk myself out of a job a lot. I mean, P less than 0.05 is not the reason to do research, and statistical tests are just dumb tools to answer your research question. If your research question is poorly developed, it does not matter what statistical test was used, how complex a statistical analysis actually became, those answers, those statistical results become more and more useless. So again, take all the time necessary to answer and develop your research questions. So thinking through PICO format, let's walk through an example. So, my team sees about 70 to 100 proposals per year, and I can basically pick and choose some of the questions. Now, this is an example taken from a journal article cited in the footnote here, but it's a pretty good example of the types of questions that we see the first time a study proposal is kind of passed towards my team. So the research question in this case is 0.15% ropivacaine as effective as 0.15% ropivacaine plus 2 micrograms of fentanyl in managing self-reported pain. So this is a very common type of question that we would see. So the question becomes, if we're thinking about that PICO format, can we answer from this research question? Can we fill in all of those categories? So let's break it down. What's the population? That is fully undefined. Somebody who was an OB might know that this is likely due to OB-related pain. But again, don't make that assumption. The intervention in this case is ropivacaine. The comparison is ropivacaine plus fentanyl. In this case, they could be switched, but both of those can be filled. The outcome is self-reported pain, but that is super generic. And so we'll talk about that in a minute. And then the time frame. So again, how long are we following these patients, et cetera. So we need operational definitions. We need to clearly define the study population. We need to define the pain outcome. How is it measured? What is the definition of it? How often is it measured? And then, related to the post-delivery time frame. So if we rephrase that question into something that satisfies all those PICO criteria. So in women who delivered via C-section, is 0.15% ropivacaine as effective as ropivacaine plus fentanyl in managing self-reported pain as measured by a visual analog scale every 6 hours during their post-operative length of stay. Okay. So now we can look at it in terms of our PICO format, and we can see that we're actually satisfying every single criteria. So one of the other issues that I see a lot with folks when they're developing their research questions is what's going on internally in their minds just isn't making their way to paper. And so, if my team sees a study proposal with this research question stated at the top, better believe there's just going to be a comment that says, I think you need to expand on this a little bit, and here's why. So again, kind of gentle nudging to move the PI towards being able to complete that PICO format. So that question was taken directly out of a journal article. One of the other things I can do is basically take some of the questions that we got at first pass on the study proposal forms and then how they were modified by the time the final study proposal was actually completed. So let's take an example of GI. So is there a relationship between serum bicarbonate on presentation and severity and outcome of acute pancreatitis? That's a mouthful, but it doesn't really say much. So we improve that. So in patients with acute pancreatitis admitted from the ED, is bicarbonate drawn within 24 hours of inpatient admission associated with severity of AP as measured by the Atlanta classification, as well as in-hospital outcomes that include organ failure, AKI, and in-hospital mortality. So again, much more specific. We can pull one out of surgery here. So is there an effect of preoperative, postoperative, and intraoperative variables on the outcomes of upper extremity orthopedic injuries and treatments? I really didn't know what to do with this either. A lot of back and forth with the PI, and we found out that they actually were looking at shoulder rotator cuff repairs. They wanted to look at pre to post surgery changes using the ASES shoulder score, and they wanted to know whether it was associated with demographic and clinical characteristics. So again, if you're having problems writing up your research question, really think through that PICO format. If you're questioning whether you're actually satisfying it, give your research question to a colleague to review, provide them with the PICO format, and just talk through it. Again, a few minutes of time here go a long way in clearly defining what the purpose of your project actually is. So once we have our research question, the next step for some studies is to develop the hypothesis. Again, if you have a hypothesis, you're moving more into a confirmatory type of research. Some studies don't have hypotheses, very exploratory. They don't really know what they're going to find, and that's perfectly fine. Just, again, pick a lane and stay within it. Don't start with an exploratory research question, and then after you find, after you have the results, move confirmatory and basically make up that you had a hypothesis the whole time. Again, so if you have a hypothesis, let's go ahead and state those. So basically, a hypothesis is what you expect to see. Some of you may recall from your statistics courses, wherever they were received, that there are generally two flavors of hypotheses. There's the null hypothesis and an alternative hypothesis. The null hypothesis is basically that there's nothing going on. The two groups are equal. One variable is not associated with the outcome, etc. The alternative hypothesis is some contradiction of that equality. So, the treatment group will have a better outcome than the control group, or age is associated with, poor outcomes for shoulder surgery or something along those lines. In general, again, your hypothesis must be stated a priority, and it must have clinical value, even if P is greater than 0.05. One of the things that absolutely drives me crazy is the reliance on P less than 0.05 to tell folks what's important. That couldn't be further from the truth. P-values, statistical analyses are just a piece of evidence. You really want to make sure that your research question and your hypothesis have absolute clinical value, irrespective of what you find. They also must not be nested in emotion. It's difficult to defend emotion because others might not share your emotion, which can lead to unethical research behaviors. If you really, really think I'm going to find this is what I feel, this is how it needs, this is what I need to find, you may just keep digging and digging and digging until something pops statistically significant. More than likely a type 1 error. That's a form of p-hacking. Again, big picture of all of this. Why am I kind of harping on hypotheses? Well, statistical tests, again, they're just dumb tools, and they're used to test research questions and hypotheses. So again, if your research question is poorly developed and or your hypothesis is poorly developed, the results of the statistical test become more and more useless. So again, take all the time you need to think through both your research question and your hypothesis. Taking a little closer look at alternative hypotheses, there are generally three flavors of alternative hypotheses. The first is a superiority, basically show that one treatment is better or worse than another treatment. If you've never heard of a superiority hypothesis, that's because every single hypothesis you've ever learned was a superiority hypothesis. In general, this terminology is not rolled out to folks in their training until they're deeper into their training or after. So again, superiority, one treatment is better than another treatment. There's also non-inferiority. This is the do no harm. You want to show that one treatment is not worse than another treatment. And there's equivalence trials. So equal efficacy, show that two treatments do not differ. Equivalence is effectively how generic drugs are developed. They can't be better than the label. They can't be worse. They need to have equal efficacy. For both non-inferiority and equivalence hypotheses, it's not a matter of p less than 0.05 or p greater than 0.05. What you really need to take the time to define is your minimum clinically significant difference. This is the point at which something clinically meaningful happens. I'll have an example of this coming up. But the minimum clinically significant difference, again, is absolutely required for non-inferiority and equivalence hypotheses. So one of the questions that I generally get at this point is, well, how do I know which alternative hypothesis I'm actually using? And that depends on your phrasing. So you really need to choose your words carefully. The best way to show this is to go ahead and show another example. So here's the research question related to ropivacaine that we had stated earlier. Let's take a look at an initial hypothesis. So pain levels will not be statistically different between patients receiving ropivacaine versus patients receiving ropivacaine plus fentanyl. So again, fairly straightforward, not statistically different, but again, there's nuance here as to what actually is planned to be tested. So let's take a closer look. As phrased, this is not an equivalence or non-inferiority hypothesis. The term not statistically different does not imply equivalence. Okay, equivalence is dictated by that minimum clinically significant difference that is defined before the study is conducted. It's unclear at this point which pain measurements are actually going to be tested. So again, in the research question, we were measuring pain every 6 hours during their postoperative length of stay. Are we talking about, at this point, not statistically different at every single measurement? And then how different can pain scores be? Again, we need to define that minimum clinically significant difference. So having that back and forth with a PI might lead to this type of hypothesis. So pain levels at each 6-hour postoperative measurement during the first 2 postoperative days will not average more than a 0.5 difference between patients receiving ropivacaine and patients receiving ropivacaine plus fentanyl. What that means is that the two groups, one group cannot be a 0.5 worse or a 0.5 better than the other group. And if they are, basically that equivalence has now fallen by the wayside. So again, this is not a question of some p-value. It's based on the confidence interval around the difference in average pain at each measurement. Yeah. So if we're going to pick on some cardiology hypotheses that I've seen over the years, here's one: novel oral anticoagulants are effective in management of left ventricular thrombus in patients with acute MI or cardiomyopathies. Are effective defined as what? A little bit cleaner is, compared to warfarin, patients receiving those NOACs will have lower cardiovascular specific mortality and stroke specific readmission within 1 year of that index hospitalization. So very specific. The fact that they're saying will have lower and higher outcome values imply worse means that this is a superiority hypothesis they were actually interested in testing. Let's go back to GI. So there will be no clinical difference in the quality of bowel prep with longer wait time to colonoscopy after the last dose of bowel preparation. So there's a lot going on here, a lot of questions related to how bowel prep is actually prescribed to the patient prior to colonoscopy. And so after that, because they were interested in no clinical difference, I came back to them and said, well, how different can they be before something clinically meaningful happens? They came back and said there'll be no more than a 10% difference in the quality of bowel prep as measured by the BBPS between patients completing that bowel prep within 8 hours and patients completing it within 2 hours. So again, just a little bit of back and forth. I made sure when this one came across my desk that they actually meant no clinical difference. And once they were sure that they wanted to do equal efficacy or that equivalence piece, then we started to have the conversations about that minimum clinically significant difference. Okay, so we have a research question. We have our hypotheses. The next piece is the study design to actually answer those research questions and test those hypotheses. So study designs are driven completely by your research question and your hypothesis. Again, beating the drum here, statistical tests are just dumb tools. If you don't have a quality research question, if you don't have a quality hypothesis, or you have a poorly designed study, the results of those statistical analyses are useless. So take all the time you need to work through the question hypothesis and the study design. All study designs are flawed. Okay. What that means is that all research is flawed. That's not necessarily a problem, though. Some flaws are poison pills, some are less poison pill-y, but you just need to work within the limitations, the flaws, and the biases of your study and stay in your lane. So once you understand the biases associated with specific study design, you'll be able to speak to the level of evidence related to your study. So we're going to talk about 4 different types of study designs here. The first is randomized controlled trials. I'm sure you're all familiar with that. It's the gold standard, meets causality requirements, high internal validity. Requirements are at least 2 comparison groups, including control, and with patients randomized to one or both of those groups if you're doing a crossover, and protocol adherence. So it has initial equivalence and ongoing equivalence during the study environment. The limitations, though, are many. All of that causality, all of that internal validity really degrades the ability to make generalizable statements. Randomization might not always be possible or ethical. And because the inclusion-exclusion criteria for most randomized controlled trials is so tight that it's very difficult to evaluate individual differences. So precision medicine does not really lend itself to a randomized control trial. But that said, if you can do one and you have the time and the funding to do one, that internal validity piece is directly related to higher quality evidence because of the causality piece. In situations in which you just have one single data set and you want to examine an outcome and maybe some sort of risk factor or exposure at the same point in time, you're going to use a cross-sectional design. Because it's cross-section, we're talking here about prevalence. If you're using that risk factor or exposure, you actually can obtain the odds of some outcome. We'll talk about that in the example coming up here. So the requirements are you're going to identify the outcome and then maybe evaluate for that risk factor or exposure. Examples. So the prevalence of HIV in patients presenting to your clinic with a sexually transmitted infection. If you wanted to look at a risk factor, you could do the odds of HIV. Do they differ between male and female patients who present to the clinic with an STI? The biases associated with this are selection bias. So are the patients different for some reason? Recall bias and confounding directly related to the data being collected. A case control study is going to take that cross-sectional study a step further where you're actually interested directly in the association between an outcome and some sort of retrospective exposure or risk factor. Here, you're going to be presented with odds of some outcome. Importantly, a case control study is always conducted retrospectively because you're going to be identifying those with or without the disease. So you already know the outcome. And now you're going to look backwards to see if they did have that exposure or risk factor. Some examples of a case control design are the odds of SSRI use in patients with or without an upper GI bleed. So you'll identify patients with or without an upper GI bleed for your cases and controls and look backwards to see if they had SSRI use. Another example is odds of lower vitamin D intake in patients with or without migraine with aura. The biases associated here are very similar to the cross-sectional design and pretty much directly related to your ability to identify the data retrospectively. If you wanted to follow patients forward in time, this can be done retrospectively or prospectively. I'll describe that in a second here. But you want to evaluate the association between exposure and some prospective outcome. Here we're talking about risk. You're going to identify those without the outcome, and then you're going to follow them forward in time to identify new cases of the outcome. So risk of new co-infection in patients with COVID-19, risk of depression in patients undergoing surgery for head and neck cancer. I said the definitions and how I'm laying out the cohort design here lends itself more easily to really thinking through this as a prospective study, but it can be done retrospectively via chart review. You would go back and identify patients who meet inclusion criteria at some point in time in the past, and then you would follow them forward from that point in time, looking for new incident cases of the outcome. Biases, again, directly related to the data that you actually have available. The one bias that I really want to cover here, though, for the case control and cohort designs is your selection bias. Basically, what that means is the groups might not be directly comparable. If they're not directly comparable, doesn't matter how complex the statistical analyses got. Again, those results are effectively useless. So for a case control design, the control group might not be representative of the target population, might be differential response rates, inadequate retrospective data. For a cohort design, you might have differential lengths of follow-ups or loss to follow-up between the groups, inadequate retrospective data. Again, the big picture here is that your inability to control for that selection bias will effectively invalidate any study results. So you really need to keep that in mind. So one of the examples that came across my desk a while back is related to is lower socioeconomic status associated with higher odds of cervical cancer. They initially wanted to do a case control design. So their outcome was cervical cancer. So those are your cases versus the controls who do not have cervical cancer. And then they were pretty sure that they could measure SES by an interview. And that interview was actually occurring in real time with these patients as they were going. So the case definition in this case would have been female patients in the statewide Nebraska DHHS cancer registry who received cervical cancer treatments. The control definition is female patients without cervical cancer treated in Omaha CHI hospitals. So again, you can see the selection bias here. So the state cancer registry only contains patients who had cancer. In this case, we're talking specifically about cervical cancer. So the question was, well, where can I get a control group? Because it's not going to be provided in the cancer registry. Well, I'm located here in Omaha. Let's just take all patients here in Omaha. Well, the Nebraska Cancer Registry is statewide. Obviously, Omaha hospitals are located here in the Omaha metropolitan statistical area. So again, there's likely to be very different associations with cervical cancer for those who are across the entire state versus those who are just here in Omaha. Obviously, not all examples are this obvious, but again, this is something to keep in mind as you're designing your studies. So how do you control for selection bias? Basically, you need to balance cases and controls on those observed demographic and clinical factors. That's true both for case control and cohort designs. It can get really complex statistically. Well-designed studies, well-designed prospective studies require very simple statistical analyses. Much of the work is done at the design phase. If you're using retrospective data, that's really where the statistical complexity comes in. So there's generally two ways to handle or equate basically observed demographic and clinical factors between your two groups. The first method is called a multivariable regression model, basically multiple predictor variables. The other way is to use propensity scores. You can match, there's inverse probability of treatment weighting, you can stratify, you can use the propensity score as a confounder. But again, they're both serving the same purpose, to really control that selection bias so that you're trying to get a unique effect of your treatment or risk factor or whatever it may be on the outcome after controlling for all of the demographic and clinical factors that are related both to receipt of treatment and the outcome. The big picture takeaway is, in either case, you probably should talk to somebody who really understands the statistical analyses. My team is called Statistics and Analytics. So again, very complex, very quickly. We are well versed in all of these methods, and the methodological literature guides us into which method is most appropriate for your study, depending on the specific characteristics of your study. So we will talk about both options with you, but in general, we're going to be guided by best practices, best statistical practices to choose which model is going to work best for you. So, big picture takeaway of all of this: make sure your research question has all the operational definitions to satisfy the PICO criteria. Make sure your hypothesis, if you have it, is clearly developed and phrased in a way that you want. If you want a superiority hypothesis, do not phrase it as an equivalence or non-inferiority or vice versa. And then once you have your research question and hypothesis, really think through the feasibility of conducting the study, choose a specific study design that is going to work for you, and then work within the limitations of those study designs. When study proposals come across my team's desk, really where we spend most of our time is in these methodological concerns. If we can't get through the methods of how your study is conducted, there's no point in us writing up a statistical analysis plan. We spend a lot of time methodologically talking with you and working with you. If all of this seems a little bit daunting, I mean, I basically rolled through this in 20 minutes. It's probably because it can be, but the reality is you have to start somewhere, and fear of making mistakes should not preclude you from trying to conduct research. There are a lot of people here, my team, and around here at Creighton, who are more than willing to take the time needed to help you move in the direction you need to. So much of this is an iterative process, back and forth, particularly with my team, making changes, making sure your study is actually being set up to answer the research question you want to answer. So with that, I'm going to turn it over to Dr. Tierney to speak to mentoring clinical research projects.
I'm muted, but not anymore. So thank you, Ryan. Ryan is, for those of you who've taken his GRS selectives, his GME workshops, they are extraordinarily well taught. If you would like to view his GME workshops or sign up to be involved this year, you could either get in touch with Ryan or Brianna Conyers, because there is an 8-hour GME workshop that Ryan does that I would really challenge anybody to give an 8-hour workshop that's as inclusive and is filled with humor as Ryan's workshop. So it's another great resource for individuals to have. Obviously, from a statistical standpoint, it scratches the surface, because that's why we have Ryan's team. And Ryan's statistical team in Omaha consists of Ryan, Danny Dilsaver, and Alex Hall. And now we actually have there are statisticians, one at Valleywise and one at St. Joe's that are particularly utilized in those hospital settings, et cetera. But we have a brand new hire for a statistician for the School of Medicine on the Phoenix campus. And Ryan, do you think I can say his name since he accepted yesterday?
Sure.
So it is Paul Kang, who some of you in Phoenix may already know. Doctors Gridley and Dorman have worked with him in the past, but that's going to be a great new resource available to mentors and to learners starting February 5th in Phoenix. So if you want to be a clinical research mentor, and so this is primarily faculty directed, but it's also directed towards graduate learners, residents and fellows who can be mentors now or mentors in the near future. But there are just some important business related things I'd like to sort of go over that are really crucial for mentorship. And some of these may seem basic, but you'd be surprised how often they don't happen. So let's say you want to start, make sure your chair knows, your research champion in your division knows, or the person who runs your research interest group. It would be also great to let Brianna Conyers, Sandy Byers, and Miguel Labrego know, because the latter three individuals are the people who connect medical students with clinical research mentors. And so them having an understanding, they can also add you to the list that is available, that students can sometimes look to themselves through the Blue Line sites that are available. But the more, if you want to mentor, we would love to know. And because there are lots of more students who want mentors than there are right now mentors available to mentor students. And just make sure you let them know what kinds of projects that you'd be willing to mentor, and just the other practical information. And then if you have particular desires about you, that you really feel that what you're doing is more focused to fellows and residents and students, that's also really useful information to know. This lecture, keep it for future reference. You can, as I mentioned before, listen to Ryan's 8-session GME workshop. There are given every year, and we send out the information from the Office of Research, as well as it sent out to faculty listservs, but some really excellent grant writing and mentoring workshops. As I mentioned earlier, Dr. Hansen and Brianna are involved in some of those mentoring workshops. So there are some that are university-wide and some that are more specific to the School of Medicine. But look for those, or again, if you would like to inquire as to when and where those are happening, Brianna Conyers at creighton.edu is your source for getting that information. Now, coming soon, actually, the latter part of this semester, we are going to begin what are called investigator boot camps. And I want to give attribution to Dr. Lee Morrow, who began this about, I would say, 1.5 to 2 years ago. And so we're going to do our investigator boot camp on what we call the modified Morrow method. But it will be where there'll be 1 or 2 senior clinical research mentors on the Phoenix campus. That will be Doctors Gridley, Curtis, and Dorman. On the Omaha campus, Ryan, Dr. Walters, Dr. O'Keefe, and me. So either 1 or a team of 2 of those individuals will join up with 3 individuals who want to learn some basics of not so much, but mentoring through understanding research design. And those models are either going to be a 10 to 12 hour day at an off location site, where mentoring begins once you get in the car and you've had your cup of coffee, or 5 2-hour sessions. And the individuals who will participate in those will be selected by the chairs of their department. And there'll be more coming out about that in the next 1 to 2 months. Could you advance to the next slide, please? So there are some policies and requirements for someone who is going to be a mentor of student or graduate learners. Clearly, you need to read and sign off on all their proposals and data requests that go to the clinical research offices in either Omaha or Phoenix. Students cannot be PIs on, I believe, any project in Phoenix, but they can't be PIs on projects in Omaha. They can be PIs on projects in Omaha that are only retrospective database projects, as long as they have a mentor that signs off on that project. But any project that requires data pulls that will involve PHI, and clearly in any greater than minimal risk studies, students cannot be PIs. And so therefore, the clinical research mentor has to be the PI on that study. There are some exceptions where residents and fellows can be PIs on studies that are not greater than minimal risk, so ones that involve PHI. And but those questions can be asked of the clinical research office on a case-by-case basis. If you want to be a mentor, you have to keep your city training up to date. Colossal pain in the petunias, I understand, but important. I mean, the information that's involved in city training is, as we all know, really crucial and valuable. I think the frustrating thing often about city training is it's fairly redundant. If we could make it more succinct, we would, but as of right now, it is the best tool to get the information, to understand the regulatory and IRB processes. And so that city training needs to be up to date. So it's always good to be forward thinking about that as opposed to having to do it at the last minute. And you will get updates and reminders when your city training, like mine, is actually at the point where it needs to be renewed in the next few months. It's also a requirement of our IRB that an updated signed CV be present in the clinical research office. And those are actual signed CVs. So you don't have to bring the whole CV down. You can send the email, but the cover page needs to be signed. So that's not the CRO being, or the IRB being difficult. It's actually a requirement of the boards that or the accrediting standards that review IRBs. One of the things that slows a process down more than anything else from a clinical research standpoint, and we mentioned this the last time, is once a proposal is approved and there are, multiple individuals on that protocol, but the first person it goes to beyond regulatory is the PI, or in most cases, therefore the mentor. And so that individual needs to sign off first before it can go to the rest of the team. So just remember that the process of going in and signing, once you've done it once, is very quick. But by not doing it and putting it off, and I know how unbelievably busy everybody is, but it actually creates a backlog. So as if any mentors could be sure to sign off on their projects in InfoHead as quickly as they can, that really helps the turnaround process. Sometimes the IRB, and the one thing I just want to reinforce right now, one of the CRO's major jobs, right, is to get the proposal ready to submit to the IRB. And we try and help you make sure that everything that the IRB is going to want is in that proposal, and is in that proposal in a well-done fashion. But we are not the IRB. And so once we send it to the IRB's review is done by a group of experts, and they may indeed have questions. They may suggest modifications to the protocol or the informed consent. They relay that information back. and/or we may make suggestions ahead of time. A lot of times, students in particular will not really know what to do with those CRO suggestions. So I just encourage you to be supportive of students when they say, gee, how should I approach what the CRO is suggesting I do to improve, or the IRB. Next slide, please. Caroline Newble is the grant administrator for the School of Medicine. So she works very closely with SPA in terms of preparation of any grants that are going to go for external funding. So, and for the budget formation for both studies that are requesting internal funding or external funding. So again, make sure Caroline is really good at budgets. She also loves budgets. So the earlier you talk to her about a budget formation, the better the budget will be. Next slide, please. So once the IRB approval is received, early on, meet with the learner to review the operational plan of study. Be available to provide any oversight necessary to carry out the study. And if you're a new mentor and you need assistance with what kind of oversight am I supposed to provide? Can I have some backup and help here? If that's not available within your department, and that's becoming increasingly available as we've been recruiting increasing numbers of folks with significant academic experience. But please either contact Ryan or contact me, and we'd be happy to help provide the guidance itself or to point you to somebody who can. And once so for many of you may know this, if you're new, you may not, but there's a tremendous benefit from the statistics and analytics team here that doesn't exist in a lot of places. So you can actually meet with Ryan and his team ahead of time with your students to actually, or the students themselves, but it's better in a team-like way to help with trial design. But then once the data are available, they will actually analyze that data, report the results with an interpretation back to the student and or whole research team. And then if indeed they get the go-ahead that the time is you are ready as a team to write up a manuscript for abstract, poster, or other presentation, will then help in the writing or complete the writing of the results section. But meeting with the learner once those results come out, or with the learner and Ryan's team, will actually move the next steps along towards publication a lot more quickly. Next slide, please. And then obviously any abstract or manuscript needs to be thoroughly reviewed and signed off by all members, anybody who is an author, but particularly the mentoring author. If indeed those abstracts are accepted for presentation at a meeting, there is a guidance for a student travel policy, probably where this link here will take you to that policy. And the person who knows how to work that policy better than anybody else is Brianna Conyers. So if you want to support a student to travel to present something, please access this link and her knowledge. Okay, next slide, please. So I just wanted to reinforce that the leaders of clinical research on the Phoenix campus, so for mentorship, so Dr. Jeff Curtis and Dr. Pooja Dorm are senior clinical research mentors on the Phoenix campus that have some time available to help support, so mentoring the mentors. Dr. Curtis is also the vice chair for clinical research on the Phoenix campus, and Dr. Dan Gridley is the assistant dean for clinical research on the Phoenix campus. I'm the chair of the department and the associate dean in the Omaha campus, and Ryan is the vice chair on the Omaha campus. And then as one other individual important to mention is Dr. Ann O'Keefe, who is in public health, but also in clinical research, and her capacity with public health databases and informatics can also be very useful. So with that, I'll end, and we would love to entertain any questions that you have, either for Ryan or for me.
Thank you so much, Dr. Tierney and Dr. Walters. You make research sound so exciting and makes people really think, okay, I can do this. You make it accessible. So thank you so much. I do have a few questions that have already come to me in the chat. So let's get started. The first one goes back to the beginning. So maybe Ryan, about the research question. When using the PICO anagram, do you usually publish with the full question as the title? Some of these questions can get quite long, and it may add more confusion in a title.
No. The title generally has to be eye-catching. How specific or eye-catching you want to get, in my experience, has varied from department to department. And so, if you want to make very, specific statements, you can choose the title however you want, but obviously you want your title to represent the purpose of the study. Again, some go a little more generic, just kind of stating, the purpose of the study, and some get very specific, with what was actually found to kind of stir the pot and be a little more eye-catching. So, but in general, no, the PICO format is not used for the study title.